Akwaba. Moho to sing. Very good. Welcome, Mr. Walter Amon, and he's going to get us started.
Good morning, everybody.
Good morning.
A young man asked me a question last night during the reception. He said, why is it that the health system is not working in Africa? And I said, it's because of our leadership. There are two kinds of leaders. Those who have the passion, the ambition to help and improve the lives of the fellow men. And then the second one is those that want to really progress at the expense of their citizens or their fellow men. For Uscaih, we are lucky to have someone who is very hardworking as a leader, who motivates, dedicated, very ambitious, and a mission to help all immigrants improve their welfare. No boundaries. It's a great honor to invite to the podium the Executive Director of Uscaih, Janet Afwaka.
Thank you. That was nice. I didn't expect that at all. But thank you all so much. So my name is Janet Afwaka, and I am honestly very, very happy to be here today. I met so many of you through just communication through the emails, but it's so nice to meet you personally now and seeing your faces and with the names, and I appreciate you all taking your time. Through the rain you came, so I'm very happy that you all did come in today to celebrate us, recognize us. The conference is really just so we can come up with a strategic plan, some kind of form, an action plan to help to advance the health of African immigrants. So thank you for taking on that lead with us. So Uscaih, I'm giving you a little bit background in Uscaih. It was initially a project through the Office of Minority Health, and it was by Ms. Margaret Koto. I slept last night, maybe 2 hours, so bear with me. It was by Margaret Koto with Dr. Emmanuel Koku, and they put this project together, and along with Dr. Commodore Manson and Idalia Sanchez, and they have really gotten the community together, especially working with the researchers to sort of give us the data that we need, the information that we need to be able to make the case, which is, our community need you and the resources. And so I really thank you all for those who started the project and now ended up on my lap. So I took over, I think, a year ago, and decided to register it as a nonprofit organization so we can do a little bit more than just the annual conference. So now we want to partner with you, collaborate with you, form a coalition so that we can really see what the needs are and who can provide what resources. Because a lot of times we think we can do it all. And really public health is a community effort. It's a partnership effort. And so I'm really excited that you all are joining us to do that. And I'm going to make it short because we started a little late. But I'm honored that you all are here, and I'm grateful that we got the opportunity, Hopkins work with us to have this opportunity to, get together and present on information that's really needed. So with that being said, I am going to invite Dr. Commodore Mensa to the stage, and I'll give you a little bit of information on Yvonne Commodore Mensa. She is associate professor at the Johns Hopkins School of Nursing and the Bloomberg School of Public Health's Department of Epidemiology. Her work as a nurse, scientist, and cardiovascular disease epidemiologist address cardiovascular health disparities among African descendant populations in the diaspora, and Africa. As a co-principal investigator of the ADHINCRA study, she led a nurse-led mobile health initiative to improve hypertension control in Ghana. Dr. Commodore Mensah also, um, I'm sorry, is a fellow of American Academy of Nursing and American Heart Association, and she serves on the board of advisory boards such as the National Hypertension Control Initiative and the American Heart Association for Baltimore and Greater Maryland. So with that being said, I am absolutely honored. She may not know this, but she really is one of my heroes. So I welcome you, Dr. Commodore, to
Good morning. Good morning. Thank you, Janet, for your leadership and really working extremely hard to make today happen. My name is Yvonne Commodore Mensah. Achomi Yvonne. This is my mother tongue. Originally born in Ghana, and this is my work home. And so I want to take a moment to welcome all of you to the Johns Hopkins School of Nursing. Thank you. Okay, so it says on your program that I'm giving opening remarks, but no, I have the distinct honor of introducing a dear mentor and colleague, Dr. Lisa Cooper. So I'll tell you a little more about Dr. Cooper. She is, if you look at the program, she's done a lot, right? And when I was a doctoral student here at the Johns Hopkins School of Nursing, I remember the first day, the former dean mentioned her and said, "You have got to meet with Dr. Cooper." And I went to her office. This is 2010, 14 years ago. I went to her office and I talked to her, and I walked out of her office changed, forever changed. I'm who I am today professionally, really because of the exceptional mentorship that she's provided. So let's get to it and get caught up with on time. So Dr. Cooper is a Bloomberg Distinguished Professor of Equity in Health and Healthcare. She's also the James Prize Professor of Medicine. She directs the Johns Hopkins Center for Health Equity, the Johns Hopkins Urban Health Institute. She's also core faculty for the Welch Center for Prevention, Epidemiology, and Clinical Research. And I love this one. She's the member of the PCAST, the President's Council of Advisors on Science and Technology. Y'all, we've got an African immigrant on the President's Council of Advisors. And like I said, of all of these professional titles, my favorite is that she's my mentor and friend. I don't want to steal her thunder because she's going to tell you about who she is. And I said she's from Africa, but she'll tell you exactly where. So again, without further ado, please, let's welcome Dr. Cooper with a round of applause.
Thank you so much, Yvonne. Such a kind introduction, and thank you all for such a warm welcome. And then let me extend my welcome to all of you to Johns Hopkins. And when Yvonne told me, I didn't know it was called Uscaih. What a beautiful sounding name that this organization wanted to host its conference here and was looking for as some additional support. It took me 10 seconds to just say that I would be so thrilled and enthused for the Center for Health Equity here to be a supporter and a partner. So welcome. So it's a pleasure and an honor to speak to you today. I know that this room is full of experts on this topic, and actually you'll hear from my remarks that I had always wanted to study African immigrants and Africans in my research, but at the time that I met Yvonne, I was really focusing on African American populations. So I've learned a lot as a result of working with Yvonne, and I'm sure I'm going to learn a lot from all of you. So I just have a few objectives for my remarks this morning. First, I'm going to describe very briefly to you of my journey to a career in health equity research. we will discuss a few what health disparities and health equity are from a U.S. and a global context. I will share some lessons from the building and the sort of maintenance and evolution of the Johns Hopkins Center for Health Equity, doing more than a decade of community engaged research there. And then just talk about, of course, the topic of the day, like the importance of immigrant health for global health, and specifically the importance of African immigrant health for the health and health equity of Black populations. So first, just origins of my journey. Some of you know already, but I was born in Liberia, West Africa, small country there on the west coast, founded in the early 1800s by freed slaves and free Blacks that returned to Africa from the United States and from other places in the world in search of freedom and a better life, because despite the fact that some of them were already freed, they were not living as free people. So, the picture in the far right upper corner shows that there was a meeting between those that returned to the continent and those who were there. And to this day, that remains a struggle in Liberia. As you know, human nature is for us to look for differences as instead of like commonalities, but we remain a country of Black people from numerous parts of the world, of course, all originating in Africa to begin with. And the people on the bottom right of my slide are my parents. So my father was Henry Nehemiah Cooper. He was a surgeon who left Liberia, came to the U.S. for his training, and he and my mother were childhood friends, but they reconnected, and they decided after pursuing their education in the United States to return home to give back to their country, and they established a small hospital. That's a picture from like the early 1960s called the Cooper Clinic. And so, they taught me and my brother and sister, that's us there in the corner, about the importance of giving back to your community, and also the importance of knowing that to those whom much is given, much is expected. So I grew up within that context and my father's mother was also a nurse. So I sort of grew up in a medically oriented family. And my mother is still alive, thank God. She is turning 95 in a couple of weeks. She's a librarian. So when I think back, I think I sort of got some of my kind of organizational and researchy type of interest from my mother, and maybe my sciencey and healthcare interest from my father's side. So that's a little bit about me growing up in Liberia. I left Liberia shortly after my 17th birthday. Many of you are young, so you may not remember, but there was a coup in Liberia that actually happened on my 17th birthday. And shortly after that, of course, we ended up leaving. There was a lot of violence. Many people killed, people who were friends and family members because they had been involved in some way with the government, or because they were middle or upper middle class, and there was a clash between people who had more and people who had less. So I think even at an early age, I was aware of the fact that there were differences in opportunities to be healthy in our country, right? You could see, I went to a private school. My parents had a driver who would drive us to school, and then there were other kids who were like walking without shoes. Many of you, if you have lived in Africa or grown up there, you know that there's poverty there. And on the other hand, when people have education, then they're able to afford more. And so you see a lot of health inequities in Africa. So I was already sort of aware of that as a child. And so interestingly, a lot of those differences is what led to the civil unrest and the violence in our country. So I think, even though I didn't have words for it at that time, I came to understand that that was really social injustice and that it actually had impact on people's health and well-being. So anyway, fast forward, after we left Liberia and came to the U.S., I was graduating from high school that year, so I'm telling you, I didn't tell you the exact year, so you will have to do the calculation to figure out how old I am. I came to the U.S., I went to Emory College in Atlanta, which had a reputation for training health professionals. I left there, went to UNC Chapel Hill for medical school, and then came up to Maryland when it was time to do my residency in internal medicine. So I was at University of Maryland Hospital, and a light bulb went off in my head. You know, I was working in the emergency room as the admitting officer, sometimes on the internal medicine floors, and I noticed, I mean, it was pretty obvious, but most of the patients we were taking care of were from the surrounding neighborhoods, from West Baltimore and other parts of Baltimore, mostly Black, African-American patients. And most of the health professionals were white, and most of them were middle or upper middle class. So there are lots of differences between the patients and the doctors. And interestingly, people a lot of times would ask me almost like to interpret what's going on with the patient. Like, you know, a patient comes in and says, you know, I'm feeling weak and dizzy, or whatever they would say, and people would look at me like, can you explain to us? And I'm like, wait, I'm not even from Baltimore, so all you have to do is listen to people and try to connect with them. Just because you look like somebody doesn't necessarily mean that you are automatically an expert on that population. But because of that, you know, I really became aware of the fact that people in Baltimore were almost in the same predicament that people in Liberia were in. You know, here they are in the wealthiest country in the world, and they were still struggling with being healthy. They were living in neighborhoods with crime. They were unemployed at high rates. They were getting sick at very young ages. Many of them didn't have access to primary care, so that's why they were in the emergency room all the time. It's not like people love being in the emergency room. So I realized, I was like, wow, if I had always planned to go back to Liberia, but at this point in time, there was still a lot of violence going on in Liberia and instability, and in fact, a civil war had broken out. So when I finished my training, I said, well, I can actually address health disparities right here. So that's how I ended up coming to Johns Hopkins and pursuing a fellowship in general internal medicine, getting research training at the Bloomberg School of Public Health, and then joining the faculty. And when I said I wanted to do research on Black populations and, you know, that's what it was called, or minority health. There was really no health disparities research at that time. People looked at me like I had two heads and like said, now you can't make a career out of that. Like, you could do that as a side interest, but you should really try to do something else that's of broader interest. And I said, you know what? I'm not going to do that. I'm going to study like who I want to study, and I'm going to study the problems I think are important to study. And I'm glad I did that, because of course you all know that this field has really grown, and now we are in the position, even though we still have a lot of progress to make, we are really in a position where we know a lot more now, and that we have the opportunity to make a difference. So my point being is that whatever passion you have, or whatever it is you know needs to be done, or you see a problem that hasn't been solved yet, maybe the world is waiting for you, right? So don't just sit back and don't accept no as an answer that easily. So there were people along the way who were also encouraging. Truthfully, I couldn't be where I am today without mentors like that too. In fact, the dean of the School of Nursing who introduced me to Yvonne, she was one of my mentors as well, Dr. Martha Hill. So yeah, there are really people along the way who said, yeah, this is really important and you should pursue it, and we will do whatever we can to help you. And that's who I listen to. So anyway, I'm going to talk about how we get from health disparities to health equity. So everyone here knows that health disparities are, keyword, preventable, right? Preventable differences in the burden of illness or violence or opportunities to be healthy that are experienced by socially marginalized populations. They're also unfair. So unfair, preventable, avoidable. And these differences between groups can occur within countries, as we've seen in the United States and other high-income countries, and even in low-income countries, we still have health disparities. And they clearly occur between countries. We know that people in lower income countries have many fewer opportunities to be healthy than those in higher income countries. So we have a global problem here, right? It's not limited to any one place. We also know now that health disparities are widespread. It's not just one condition, right? It's like heart disease, cancer, diabetes, infectious diseases, depression, mental health problems, all kinds of populations, infant mortality, maternal mortality is like, a global health problem, and we know that it continues to be an incredible problem even in high-income countries. People who come from marginalized groups, typically from racially and ethnically marginalized groups, and also from income and socioeconomically marginalized groups, are dying at much higher rates. We've made progress, but there still are stark disparities. And I'm going to focus more specifically on cardiovascular, because that's sort of my area of expertise. But you can see that this problem occurs across the board. It's also very costly. And that's kind of a language that certain people understand. So even if they don't really think that the fact that something is unfair or preventable means it needs to be fixed, one of the arguments that we can make is that, well, it's costing you a lot of money, It costs a lot of money. People are dying at younger ages. They're not being productive. And needless to say, it's leading to all kinds of other problems, political and civic as well. A lot of times people don't see these connections, so we have to make the connections for them. So I'm talking longer than I wanted to. I just wanted to make the point that COVID-19 came in and just sort of joined all the other conditions in terms of exposing, inequities. So you all know all of this right here, but the average life expectancy clearly is much lower in less developed countries than it is in more developed countries. So you can see that for the least developed countries, the average life expectancy for men and women is like age 63 or 67, whereas in the most developed countries, it's much higher, 75, 81, right, for men and women. So these are some health disparities. The other thing we know is that the causes of death are tending to shift over time. So these are just projected deaths by cause in high, middle, and low-income countries. And this is projecting up to 2030, and you can see, like, by looking at the lavender and gray bars, in particular, that the non-communicable diseases are the ones that are dominating, right? And the fact that they are consuming a larger and larger proportion of the contributors to mortality in low-income countries, and we're not ready for this. So we really have to pay attention to health disparities on a global level. These diseases are really making quality of life and mortality rates much worse. I like to show this slide because I think a lot of times people are like, well, health disparities, especially in healthcare, it's because people just don't eat right, they don't exercise, they smoke, they use drugs, what do they expect, right? Well, we know it's like a whole causal chain. It doesn't start right with the individual. It starts at the societal level. So we already start with our social and cultural norms. We decide on a social level, like, who is what's the norm, like who's most valued and who is less valued, and based on these attitudes, this racism, sexism, ableism, classism, homophobia, these are things that really kind of are what we call systems of power, and it's really hard to measure those things, but they're there, and they kind of determine who is in charge of the institutions. And so based on who's in charge of the institutions, that's where the power comes from, right? And that's who sets the laws, the policies, and all the practices within our organizations. So if you come from a marginalized group, there's this whole cascade of these social attitudes, these institutional factors that all of these policies and everything determine what your living conditions are, right? What's your physical environment? They call these social determinants of health, right? Can you actually get access to good education, a good job, healthcare? There's there like pollution around where you live? Do you have safe drinking water? All those things. Then you can make a good decision about what you're going to do about your behavior. But if you have all these negative things coming at you, how are you going to make decisions that are healthy, right? So we were focusing for a long time on these dark blue, on these factors in healthcare. Let's like get people to do all these things and to stop doing all these bad things and everything. But we were forgetting that if we don't address all these other factors upstream, which is what public health tends to do, we're not going to get to the root of the problem. So the issue is that we have to address everything along this whole causal chain and acknowledge that that in order to get to health equity, we have to break this causal chain in several places, right? So when we do that, then we'll be able to move from health disparities to health equity, which now the term is now in common use, but at the time I started out, nobody was talking about this, but what is it? It's the absence of these systematic disparities in health between more and less advantaged groups. So every person has the opportunity to be healthy. And I really try to focus on this because some people now want to outcome, right? But everybody doesn't need the same thing. So if we want to have health equity, we have to use different approaches for different people. It's not like one size fits all. And some people think equality is the same as equity. Well, we know it's not. Giving everyone the same thing will not get to equity. So we still have a lot of work to do to make sure that the general public understands that concept. So I want to tell you a little bit about, once I started my career, I was doing more sort of descriptive work, just describing health disparities, documenting things. Because I came to the School of Public Health and I was like, I want to improve the health of Black people in America and in Baltimore. And some people said, well, is it really a problem? I was like, well, yeah. And so, they're like, well, where's the data? So there were people who weren't really studying it, or the people who were studying it weren't actually getting the information in front of people who had power to make decisions for a variety of different reasons. So I wanted to contribute to that. And so I did that sort of early work describing just how bad is cardiovascular health in Black populations. And now it's like sort of really well known. And why is it bad? And I was focused on the healthcare system, so I did a lot of work looking at doctors and patients and how patients from racially minoritized groups were not getting the same type of interpersonal care, which was then leading to them not getting access to the right treatments. So that was where my work started, and then now it's sort of evolved into, okay, it's enough kind of telling people what the problem is, it's time to find solutions. So in 2010, right around the time I met Yvonne, was when we got a grant to establish a center. And at that time it was called something else, but now we've changed the name to the Johns Hopkins Center for Health Equity. It was called the Center to Eliminate Cardiovascular Health Disparities. Well, it's still doing that, but that's a very long name. And we wanted it to be the center for something, not the center to get rid of something. So that's what we do. We promote equity in health in populations that are socially marginalized. We do it through 3 different approaches: advancing scientific knowledge, educating and training leaders, and partnering with communities. And you all know now, but for a long time, actually, people didn't even think about, partner with communities. Like, we actually need to do that? Like, we thought we knew everything, right? So we realized pretty quickly that we didn't really know everything. We don't have all the solutions here. And also, there's no point in identifying a solution that no one is going to use, right? So that's one of the main reasons for, of course, partnering with communities, and it's only the kind of fair and equitable and just thing to do to work with people who are actually experiencing a problem in documenting it and coming up with solutions. So we've been doing that since 2010. We started out with 3 clinical trials and a small training program. We've now expanded. We have about 40 faculty members. We've trained more than 500 individuals here at Hopkins and more than 9,000 people globally, because we have courses that people can now take online for free, actually. I don't know if you've heard of Coursera, but yeah. So anyway, so again, here's our 3-pronged approach: engagement. So we have a community advisory board, lots of members from different sectors. We meet quarterly with them. We have health system partners, and we also partner with policymakers. And Yvonne told you about my latest appointment on a federal advisory group, which is a whole new learning experience. We will have a separate conversation about that. So yeah, and so then we do research. And so these are some of our recent trials. We've had a number of different trials focusing on different ways to advance cardiometabolic health equity, ranging from those that focus on the healthcare system, those that focus on enhancing food access, those that just uplift the voices of people from marginalized groups by basically getting them to tell their stories through photo voice. I don't know if you all have heard of that method of research. We work in different populations, all the way from children, people who are birthing, and all the way to like sort of older adults and middle-aged folks. And we also have a new sort of center within a center, which I'll tell you a little bit more about. And as I said, we have courses which are available online, but we also have a monthly, what we call the Health Equity Jam session. And because it's virtual, people can join us from wherever you are, like across the country, across the world. You can go to our website, you can sign up. I see Lauren Sala from the Center for Health Equity back there. She's our communications coordinator, and she sort of helps us manage a lot of that so that people from all over the world can join us and hear from experts. We also hear from young people who are just getting started, and so it's a very fun and supportive platform. So we do that. And then if you're here at Hopkins, you can actually get individualized mentorship. And we did, during the pandemic, we actually did individualized mentoring of people from all over the country. So we're still trying to do that. A lot of it is capacity building, though. We need to make sure that our faculty have the capacity. So I'm going to just go into now a little bit more about our studies, and then, because I'm talking a long time, and then keep moving. So these are some members of our team. You may recognize some familiar faces here, community folks as well as researchers. This is the Rich Life trial that I told you about that we just completed, a cluster randomized trial in Maryland and Pennsylvania. We enrolled people with uncontrolled hypertension. We were aiming to reduce disparities in uncontrolled hypertension in primary care patients, basically using a very pragmatic design. And so we compared kind of what we call enhanced standard of care. We trained all the health staff in how to accurately measure blood pressure. We provided automated blood pressure machines to all of the health systems. We provided training to the leaders in advancing health equity. So it was a very intensive program, this standard. And then the other program had all of that, but then we also had a nurse care manager and a community health worker to work with the patients who were part of the study. So those people would focus on not only the medical issues, but if the patient actually had other issues, social issues, things like the electricity being turned off, they can't figure out how to enroll for insurance, they lost their job, all of those things, community health workers could help them with those things. And we wanted to compare the outcomes between these two groups at 12 months. So what did we find? Both groups achieved significant improvements in blood pressure control. It was similar, about 56, 57% in both groups. So it went from 100% to 40% improvement. And then something like 15 to 16 millimeters of mercury of blood pressure. So we all know that is clinically important. But it was no difference between the two groups. Surprisingly, we thought really having a community health worker and a nurse care manager would really make a big difference. Where we did see the difference is that the people who had a community health worker and a nurse said that their care was better. So we know that over time, that is important, because if people don't feel happy with the care they're getting, they're not going to necessarily continue to be adherent, right? So we want to see whether at 24 months, whether we see any difference, but that's what we showed for now. And then we also showed that people who live in rural areas benefited more from having the nurse and community health worker, which has implications, of course, for other places where there's limited access to care. And then people who were sicker, people who had like heart disease on top of their hypertension. So this is another study that we've done at DINCRA. That's the one led by Dr. Yvonne Commodore-Mensah and Dr. Stephen Sarfo in Ghana. So we've branched out and to not doing only studies in the US, but also African populations in other parts of the world. And I would say this was really interesting because it was the opportunity for us to take some of the things we learned in the US, apply them in Ghana with regard to the blood pressure training and giving the patients home blood pressure monitors and working with community health nurses. But then also we used mobile technology to sort of help to overcome some of the access barriers, because everyone has cell phones now. And even those who didn't, we provided them in this study for people who didn't, but most people had cell phones, right? And so this study was dramatic, right? We don't have the results are not published yet, so nobody can take this slide and use it yet, but other than Yvonne. But you can see that there was a huge difference between the group that got all the extra stuff, right, versus just getting a text message from time to time. The people who had a community health nurse and who had the telephone app and working with them, they achieved blood pressure control. 80% of them did, versus only 24% of the people in usual care. So huge difference. This shows you actually how there's so much need, and this study was actually didn't even cost that much money compared to the studies that we do in the US, and we showed this dramatic improvement. So many opportunities here. And now, if we know that the cell phone technology can work in Ghana, then why can't we use it here where everyone has cell phones too? So you can learn a lot more about that. We also have a new center here. So several trials, again, I won't describe all of them, but these are different principal investigators. And these trials are across Maryland. So this is a mid-Atlantic Center for Cardiometabolic Health Equity. Again, pregnant women we're working with, trying to reduce gestational diabetes and preeclampsia. Older people with heart failure, trying to prevent progression of heart failure. DASH Life is people with kidney disease and diabetes, trying to get them to eat healthier diets and improve access to healthy food. And then the Linked Hearts program is the one that's actually using learnings from DINCRA, including using mHealth technology, along with now this time we have community health workers, but working with pharmacists this time, because we know that the pharmacists can really focus on the medications, whereas the community health workers can focus on all the other things that seem to get in people's way, right? So here are some of the things we've learned. We know now that you have multi-level interventions that are very promising, because you can't just address like the individual patient. You sort of need to improve the healthcare system. You need to work with things going on in the community. And if you do all those things at multiple levels, you can show reduction in disparities. We still have a lot of challenges to get over. So the reach, sometimes it's really hard to reach the people who need the programs, because maybe they're not in the clinic. They haven't come there because they can't get off work, they don't have transportation, or they lost their insurance. So that, we still have a lot of more work to address behavioral and economic barriers, tailor the interventions to particular needs that people have. There's so many different people who have different perspectives. Like you're working with a federally qualified community health center. Maybe they want something else. They need something else. They're trying to meet some kind of other performance thing, and you are trying to do a study on something that they don't really want. So you have to sort of balance those things. We need to measure cost effectiveness because people care about that. And we need to see whether these things will actually can be sustained. So these are some of our lessons. And now I'm going to move into some of our training just briefly. So you can see one of our trainees here is in the audience, our former trainees. He's a junior faculty, Dr. Ogungbe. We have wonderful trainees, just so dynamic that really shine for us. And these are the things I already told you about that we all the different things we offer. So tell that to your students. Let them know about the Johns Hopkins Center for Equity. And we partner with communities, like I mentioned to you before, in Baltimore, but then also in Africa. We've partnered with people in Ghana. We have a partnership with a university in Uganda. And so we use community-based participatory research principles. I'm sure many of you use that in your work. We know that it's a collaborative approach. It equitably involves all the partners who could be impacted by the work in the research process. And the idea is that the most important thing about this is that you don't just acquire knowledge, but you actually combine your knowledge with action to bring about change. So CBPR is not just doing science for the sake of science. It's doing science to really change people's lives, and that's what we want to do. So that's a picture of our community advisory board a few years ago. And then, we established it at the same time we established the center. Like I said, we have more than 100 members. They attend virtually sometimes, but we also have in-person meetings. And we want to make sure our work is relevant and that we learn from each other. We build capacity. So when we get input from community, we also offer our expertise to them as well. So it's a win-win situation. And they help us get the word out about the research findings and make sure people can use them. So here are the main lessons learned from community engagement to navigate, right? Because otherwise you're going to run into that iceberg and what's going to happen to the boat. So here are the 3 R's. Respect. That was one of the first things that it just is at the center of everything. Everyone has a perspective and everyone has value. And if you don't come into this work with respect for others, you can't really, there's nothing that you do that's going to matter, really, right? The next one is establishing relationships with people where people can trust you. They know they can count on you. They know you have their best interests at heart, right? They know that you're not using them for some kind of economic gain or some kind of fame or something else, right? So yeah, you're good for your word, right? If you say you're going to do something, you do it. If you don't do something that you say you were going to do, you explain to people like what happened. You apologize when you make mistakes. So all of that. Then the 3rd R is resources. So you don't just come and take away from communities. You have to offer something back. And so all of this is like, you have to share resources, right? And share power. So those are the 3 main lessons learned: respect, relationships, and resources. And then now I'm going to close with your topic of the day. So we know that world migration has really increased. So we know that even though migrants make up about 3.6% of the global population, that number has been growing and growing since 1970. And we know that the most popular destination site is actually the United States. And Germany is actually the 2nd most popular country. But you can see how it's growing in Asia and Europe, right? Their migrant populations are moving, and a lot of this has to do with inequities and opportunities in different countries. People in low-income countries, they don't want to be stuck there. They don't want to be always like not having anything. So they're moving. They're getting away from civil unrest and war and things like that, and they are trying to give back to their folks at home. So we know that there's a lot of world migration going on. We know that we've heard a lot about this healthy immigrant paradox, right? People always say, oh, well, when immigrants move to a different country, they tend to be like really healthy. Well, they start out maybe that way because what happens is the people who are able to immigrate are the people who are already healthier and the people who have more education and more opportunities. So there's a lot of research showing that immigrants are healthy when they first move to a host country, but it disappears over time. So the longer they stay in the receiving country, they become unhealthy. They become more like the other marginalized groups in those higher income countries. So that's why it's so important for us to focus on immigrant health. And then, so, we want to focus, this meeting, of course, is focused on the health of African immigrants throughout the world. And so our colleagues here, Dr. Commodore Menza and Dr. Ogungbe and others, have completed a systematic review which really looked at the health of African immigrants across numerous high-income countries. And they found that the prevalence of these conditions varies very widely across these countries, all the way from 6% in one country for hypertension all the way to 55%. So there are different countries that confer better and worse health for African immigrants. So there's hypertension. You can see obesity is high at 59%. Dyslipidemia, meaning high cholesterol, 29%. And then diabetes wasn't that far behind, 11%, 7% for smoking. So we know that cardiometabolic health is going to be an important area of focus. Of course, there are going to be others as well, but we know that it's the number one contributor to mortality. So definitely one area for you to focus on, and I wanted to highlight some of the work of our colleagues here. What do we know about Black immigrants in the United States? So 1 in 10 Black people in the U.S. are immigrants. Another 9% are second generation. So we know that just in the U.S., African immigrants are comprising a greater proportion of the Black population. What are we seeing for Black health in the U.S.? Hypertension, death rates, diabetes, health disparities. What do you think is going to happen to African immigrants if we don't work on these issues for them, all right? By 2060, it's estimated that Black immigrants are going to account for 1/3 of the U.S. Black population. So we definitely have a population group that we need to focus on. This is a very busy slide, but the point here is that this was looking at, again, colleagues from here, cardiovascular disease risk prevalence among white, African American, African immigrant, and Afro-Caribbean adults. And you can see African American adults tend to have the highest levels of these negative risk factors, and the African immigrant populations tend to have lower, but they're sort of increasing, some of them increasing over time, right? In particular diabetes, So we have to follow these trends, and I thought this was a really well done study, looking at because sometimes we just group everybody, there's all Black people, all Hispanic people. We know people come from different backgrounds, so we really have to look at the different backgrounds in which they come, because they have different risk factors and different factors that contribute to that. So I'm just going to sort of wrap up with some of our lessons learned from working with African immigrants in the U.S. Again, Dr. Commodore Menza is like my rock star mentee who really brought me into this work too. So I'm really standing on her shoulders and the shoulders of many of you in here. So we know cultural identity is important. Okay, we know that we really need to identify people by where they're from. They don't necessarily want to just be, you're just an African person. Like, where are you from? So really focus on where people are from. We need to work with gatekeepers, right? People who are trusted in communities. That's one of the principles, again, of community engagement. You don't just go into a community that you don't know and say, I want to do a study, and you need to participate. No, you get connected with people who are valued and respected in the community, and you talk with them, and then they can sort of open doors for you, right? So I know we've learned a lot about that, especially from religious leaders. We have to address stigma. There are lots of diseases that come with stigmas, HIV, COVID, things, mental health, so we need to make sure that people understand that whatever they tell us is going to be kept confidential, and help to address dispel some of the myths, right? We need to be very culturally and religiously sensitive, right? Making sure to respect customs, local customs, and customs of immigrant groups. And then it's helpful to have race concordance, and one of my top favorite topics. That's where I did a lot of my early work, is looking at the fact that people who share some common background can be effective ambassadors, right? So it's really important to involve people from the communities in the work. So those are our lessons learned, and I'm just going to close with some parting thoughts for you for the day. One parting thought, really, which you guys have exemplified here through the forming of the Uscaih. Yeah. This is my parting thought for you is, if you want to go fast, go alone. If you want to go far, go together. I know you all have heard this African proverb, but there's strength in numbers, and together we're much stronger than we are alone. So continue to stay strong together. And a quick shout out for my book, if you want to get more information or hear more about some of the work along the journey. But it's really been a true pleasure to be with you all, and welcome, and have a wonderful conference.